Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wa halul uqdatam min lisani yafqahu qawli. Assalamu alaikum wa rahmatullahi wa barakatuhu. Dear esteemed members of the forum. First and foremost, I would like to appreciate the overzealous push by Dr. Nadeem in handing over the reins of carrying forward his suggested topics for an audio presentation, which were complications associated with dental surgeries, exodontia, impactions, and implant surgeries. Since these topics are very vast individually, dealing them would be tiring and I may not be able to do justice now, and hence I will instead prefer to speak about complications following minor surgical procedures. So I request you all to kindly brace yourself, as this can get a little lengthy podcast. First things first, addressing to the initial query by Dr. Muhammad Atiq, bleeding emergencies during implant surgery are infrequent and normally self-limiting, causing the technique of implant placement to become an almost routine procedure. However, immediate bleeding complications have been described, which although infrequent may prove serious, particularly in the floor of the mouth. The branches of the sublingual and submental arteries that irrigate the lingual zone of the mandible are located close to the lingual cortical plate. These implications are an increased risk of bleeding if the cortical bone is damaged during drilling or implant placement, whereas profuse bleeding is less common in the upper jaw, and if so, may be attributed following maxillary sinus lift surgery with immediate implant placement. Coming to the basic necessity during implant placement, an adequate planning of surgery is very much required, with thorough knowledge of the anatomical features of the surgical zone, and also the use of complementary techniques such as cone beam computer tomography in order to avoid possible risk situations should be considered. Starting with the main topic of this audio presentation. Now, preparing for any surgical procedure, it is imperative that prior to any surgical procedure, we will have to discuss and record patients' medical and dental histories and take radiographs and or any further investigations as and when needed. Some professionals will prescribe antibiotics to be taken before and after surgery. These antibiotics are more likely to be given to patients with infection and or weakened immune systems at the time of the surgery, those undergoing longer surgeries, and even elderly people. When it comes to dental procedures, tooth extraction, which is very common, or having teeth pulled among patients, is most dreaded. Before we consider extraction, every effort has to be made to try and repair and restore the tooth. However, sometimes a tooth extraction becomes necessary. There are several potential complications that may occur as a result of minor surgical procedures. These complications may include and can be categorized broadly as intraoperative or immediate complications and postoperative or delayed complications. The intraoperative and immediate complications can be bleeding, fracture of the bone, displacement of the tooth into adjacent space, Oriental Communication, and injury to the adjacent structures. And in the delayed and postoperative complications, we again have bleeding, swelling or edema, hematoma, trismus, dry socket, wound dehiscence, ecchymosis, and osteomyelitis, osteonecrosis, and also nerve injury. Let's move ahead with individual complications now. The bleeding, being the first and foremost complication in both immediate and delayed categories, can become life-threatening if not addressed immediately when identified. The causes of bleeding are number one, tissue tear. This can be prevented by meticulous retraction and avoiding excessive retraction forces and proper handling of the soft tissues. And how do we manage this? Simple sutures should do the trick. Secondly, also the presence of granulation tissue may sometimes lead to continuous prolonged bleed due to the presence of multiple inflamed microcapillaries, which tend to rupture with minimal shearing forces. The management of this kind of bleed is thorough curettage. Thirdly, sometimes overzealous extension of an incision and lack of proper knowledge of anatomical structures, leading to severing or injury to the vessels like facial artery or lingual artery. This being an arterial bleed, it requires either ligation or clamping for its management. Finally, bleeding can sometimes occur from bone itself. In such cases, plugging the bone trabecula with bone wax or gel foam or even collagen plug helps control the bleed. The bleeding after a tooth is removed is very common. Now, bleeding in the mouth may appear worse than it is because a small amount of blood may mix with saliva and appear to be more than is actually present. Most problems with bleeding occur because the person frequently removes the pack to see whether the bleeding has stopped. And most of the soft tissue bleeds generally require just pressure packs for hemostasis. The second immediate complication is the fracture of bone. When we say fracture of bone, it can be starting from the immediate adjacent cortical plates or lingual plates in relation to the mandibular third molars or to fracture of tuberosity in maxillary region, and more severely the fracture of angle or jaw itself. Excuse me. This kind of complication is always attributed to the improper operative technique and use of excessive forces without proper stabilization of the mandible, so making it that much more important to control the amount of forces during luxation and elevation processes using elevator. In case of an eventuality of tuberosity fracture, the main objective should be to stabilize the segment using splints or wire. But of course, after informing the patient about the unfortunate event, then postpone the extraction until the segment gets stabilized and later remove the tooth surgically. If bone fragment is small, then remove it along the tooth and suture the socket and figure of 8 pattern. The third complication is displacement of the tooth into the adjacent tissues or structures. The most probable sites for tooth getting displaced is lingual pouch or submandibular space, the pterygomandibular space, the infratemporal space, and the maxillary sinus. Again, a use of controlled forces and proper support prevents this eventuality. The fourth complication being damage to the adjacent structures. The damage can be again to the soft tissues or to the adjacent hard tissues. The soft tissue injury can be simply a tissue tear or a puncture or a buttonhole, which can be managed by sutures. And the damage to the adjacent hard tissues can be the luxation or the avulsion of the adjacent tooth, accident removal of the adjacent crown or proximal restorations if any, and these can be prevented by carefully handling the instruments with adequate hand finger rest and support. Now, oro-anal communication is yet another intraoperative complication which is a matter of concern. Sometimes the maxillary molar roots, which are very close or divergent or very thick and in proximity to the floor of the sinus, or they can be a resorption of the bone due to a pathology, or the sinus itself can be very wide as in an anatomical variation. These are some of the causes which may lead to communications, and not forgetting the iatrogenic causes such as use of excessive forces again and improper instrumentation to luxate the tooth leading to the oro-anal communication. The diagnosis of oro-anal communication in etiology and management will be inshallah dealt with in my another presentation exclusively focusing on oro-anal communications inshallah. But just briefly, in case of oro-anal communication, management is if opening is less than 5 mm, simple figure of 8 suturing of socket will suffice. If large, then it requires flap from adjacent regions to close the opening. And the last and the rare complication in the is the extraction of wrong tooth itself. This I don't know how it can be justified other than by saying lack of focus and concentration by the dental surgeon himself or herself. Alhamdulillah, we have heard about the immediate complications now. Moving ahead with the delayed complications, the first one being bleeding again. The delayed bleeding can be due to various reasons such as smoking, alcohol, use of certain drugs like aspirin and anticoagulants, and sometimes the prolonged bleed can also be a result of secondary vasodilatation and hypertensives after the wearing off of the vasoconstrictor. Now, one other reason is the constant spitting post-exodontia procedures and use of straw to consume liquids which create a negative pressure leading to dislodgement of clot with subsequent bleed. Moving on from the bleeding, we have ecchymosis, which is again bleed in subcutaneous tissues due to increased laxity or flaccity of the tissues in the elderly. The reassurance and intermittent heat pack as a management can be considered helpful until its resolution. Edema and swelling. Edema and swelling starts after 24 hours and increases from second to third day. Fourth day onwards, it begins to subside, and after about a week, it should resolve on its own. But if there is an increase in swelling after third day, this can be considered a sign of infection. The prevention and management of edema again depends on the proper handling of the tissues during retraction, and atraumatic extraction or surgical procedures, and adequate amount of irrigation in case of use of drills and bone cutting during bone cutting, and also compression bandage and steroid injections in case of major surgeries will reduce some amount of edema and swelling. Sometimes administration of enzymatic preparations also helps in managing post-op swelling and edema. Now coming to trismus, this is an inability to open the mouth to normal limits, and causes may include muscular spasm, which results from inflammation related to operative trauma, then improper local anesthetic technique, which is penetration of needle into the medial pterygoid, and then injury to temporomandibular joint during a surgery, or even inflammation and hemorrhages arising in infratemporal fossa and buccal space. This may secondarily afflict masticatory space and produce trismus. Pain is also a sort of complication, if I can say. I always prefer to give analgesics before the effect of anesthesia wear off, so that patient is comparatively feels better. One of the most common complications after exodontia is dry socket. The term dry socket was coined by Crawford, and this can be best explained by the hypothesis of Bunn, according to which the infection and trauma causes inflammation of bone marrow, and this further causes the release of tissue activators, which convert plasminogen to plasmin, which dissolve the blood clot, and further releasing kinin from kininogen, and this causes severe pain. Signs and symptoms of dry socket are severe pain, pyrexia, empty socket which is covered with white slough and also accompanied by fetid odor. Now the management of dry socket is we should avoid curettage, and we should focus on irrigation, and sometimes the use of obtundant packs is very helpful. For example, alveogel or ZOE pack, or even balsam of Peru, or even the use of chlorombutanol 4% or benzocaine 4% is known to be helpful in relieving the pain of dry socket. The more severe forms of delayed post-op complications in manual surgical procedures is osteonecrosis and osteoradionecrosis of the jaw. The osteonecrosis is a disorder that involves the exposure of the jaw through the soft tissues, but usually associated with pain, loosening of teeth, and sometimes discharge of pus. It may occur after tooth extraction and or trauma, or it may occur spontaneously. It is also known to have been developed in some people who were given drugs that strengthen bone, which is often used to treat osteoporosis. The most common of these drugs are bisphosphonates, and the bisphosphonates seems to have a higher risk of causing osteonecrosis of the jaw in people who undergo oral surgical procedures. Treatment typically involves scraping away some of the damaged bone, thorough debridement, antibiotics, and antimicrobial mouth rinses. Excuse me. Finally, the nerve injuries, and the nerves at risk are inferior dental nerve or alveolar nerve, long buccal nerve, lingual nerve, and mental nerve. I will not be discussing the causes of nerve injury in detail, cause as we already know is that inadequate surgical planning with improper and overzealous instrumentation which leads to the nerve injuries. The nerve injuries are three types, which I will briefly mention but not going into much detail. The first one being neuropraxia. This neuropraxia is a localized block of conduction along a nerve. What happens is the axonal continuity is maintained and the conduction proximal and distal to point of injury is preserved. The recovery in this kind of injury is rapid, and restoration of normal function should occur in a few days or weeks. The second type of nerve injury is axonotmesis, in which the continuity of the axon is disrupted, and the prognosis remains good because the continuity of Schwann cells and the basement membrane is maintained. Recovery should be seen from 3 to 6 months. And finally, the third type of nerve injury is neurotmesis. which means the complete anatomical severance of the nerve, and no recovery is expected without surgical coaptation of the fiber ends. The surgical repair of nerve injuries is a whole different level, so I feel should be dealt in a different podcast altogether. And to give my closing statement, patients having routine surgery should expect to encounter mild swelling of the face, minimal bruising, and some discomfort following their procedure. Thorough preparation helps in healing and will make a positive post-operative experience. Fortunately, a skilled maxillofacial surgeon can minimize all of these complications by his or her surgical technique and experience. The advances in imaging techniques such as the use of CT scans helps in identifying patients at risk of nerve injury due to variations in the anatomy, and sometimes the antibiotics help with prevention of post-operative infection, and special tests can determine if there is a problem with bleeding. Jazakallah khair for your patient listening. The inputs and criticism are most welcome, and thank you so much.